Wouter, you're muted.
This was a test. Again, thank you, Dr. Massicott, and thank you, Ian. Thank you for asking me to talk about my favorite subject, CSF leaks. And I remember pretty well when I was in medical school in the 1980s that one of our neurology professors, Professor von Krevel, was really very excited about having this study published in the Lancet, which in Europe is really, considered the crème de la crème of medical journals. And I never really knew if he was so excited about the fact that it was published in the Lancet or that he was excited about having done this study. And it was an interesting study where he himself did 100 lumbar punctures, and he compared it with or without 24 hours of bed rest. And he found that it did not make any difference. But sort of that piqued my interest a little bit in CSF leaks. And what was interesting when you read that paper, that's now 40 years ago, is that these people were matched for age, sex, and also what was called neuroticism. And I remember the psychiatry professor who we had said that neuroticism means mainly anxiety and a tendency to complain. And I think that is the same now as 40 years ago. So a lot of patients who have CSF leaks, they're not really being taken seriously. Of course, some patients might have that, but the vast majority of patients just are seen by, so many different physicians. And it literally can be decades before the diagnosis is finally made. So a little bit about nomenclature. So when you talk about traumatic CSF leaks, it's really not just what we call an iatrogenic leak, right? Iatrogenic means a leak that's caused by a doctor. Iatros in Greek means doctor, and previous speakers already have talked about these different iatrogenic type of leaks, but there also are different types of trauma: falls, gunshot wound, stabbing, motor vehicle crashes. And I think it's somewhat important to use the right nomenclature, but it also can be difficult, right? So this is somebody I operated on a couple of years ago, had many attempts at a lumbar puncture done by a medical student. Now, of course, a medical student is not a doctor yet, so you really shouldn't call that an iatrogenic leak. But vice versa, this is somebody who we had in the hospital earlier in the year. Was a gentleman who was stabbed by a doctor 7 times. The doctor was on drugs, and he stabbed his friend 7 times. And as you can see here on this MRI scan, one of these stab wounds goes right through the spinal cord, and there's a large extradural CSF collection. Now, remarkably, this just healed all by itself without any intervention, just with a week of bed rest. And I think probably that's because he had a self-inflicted epidural blood patch that you can see here, that of course was right at the site of where the one of the knife blades went through the dura. So that is an iatrogenic leak, but in most series you wouldn't find something like that. So I think about 5-6 years ago, we started doing these digital subtraction myelograms that Ian and Christian already have talked about. But we started doing it in a consecutive group of patients with post-dural puncture headaches. And in these 27 patients, we found some type of, let's say, abnormality, I think in 9 of them. About half of them had what we call an extensive extradural CSF collection. And about a third of them, I believe, had a Bleb or a pseudomeningocele. And then just to get back to Dr. Carroll's point, we did have one patient with bilateral CSF venous fistulas. And when we found that, we were pretty excited because we thought, oh, this is probably a common cause of post-dural puncture headache with normal imaging, which, as Dr. Ulrich has told us, that's by far the most common scenario. But then when we did maybe another 20 or 30 patients with DSMs, we did not find any more patients with CSF venous fistulas. So currently we don't do DSMs anymore in patients who have otherwise normal imaging in a post-dural puncture headache type of situation. So we also don't do CT myelograms. We really just rely on MRI and MRI myelography. And this is actually a patient from Canada who sent her films a while back. You can see here on this axial slice, you see the little bleb, the little pseudomeningocele, and on this lateral projection, you see how it's right where the lumbar puncture was performed. And then this is from a different patient, and it's similar to the pictures that Dr. Ulrich showed. So you see the little pseudomeningocele there. That's at lumbar 3-4 level. And then this is, I didn't know that you could call that a neo-sac. I'm going to start using that term. You can see here upon exploration, there's this neo-sac. That's really an organized type of connective tissue dome over the bleb or the pseudomeningocele. So you carefully have to peel that off the dura, and just like in Dr. Ulrich's example, there are little nerve roots that are attached to the remnant of this neo-sac. So you have to very carefully take that off the connective tissue band and then reintroduce that intradurally, as you can see here. And then I like to use the number 10 Roten. You can kind of hook that underneath the dura, and that'll give you confidence when you close the dura that you won't inadvertently suture in a little nerve. Now, what about SLECs, right? So from Bleb to SLEC, what is a SLEC? I never use that term, but I know that Dr. Farb likes to use that term, and it stands for spinal longitudinal epidural collection. And as some of the prior speakers have shown, you can also get that from a post-dural puncture headache. So this was a young lady who happened to be pregnant at the time with very orthostatic headaches. She had seen many doctors. She was diagnosed and treated with POTS. And she came to our hospital. So one of my colleagues, Dr. Chu, and he said, wow, you know, it really sounds like you have a spinal fluid leak, which was not that surprising because she'd had many procedures done, lumbar punctures, LP shunts, for a diagnosis of pseudotumor or IIH. And then on her MRI scan, you see this extensive ventral collection, the SLEC, and then you can see that on the axial plane, it's actually causing some spinal cord deformation or displacement at least. And then on the DSM, you can tell where exactly the lumbar puncture was performed, or the placement of the LP shunt, I'm not sure. And then, as we've seen previously, that's what it looks like under the microscope. There's like a tiny little hole. Now, this girl had symptoms for at least 4 or 5 years. Now, she was pregnant, so we didn't really want to operate on her. Dr. Maya did some blood patches. She felt good for a couple of months. She delivered her baby, and then in the postpartum period, we went to the operating room. So what about post-dural puncture headache? So I haven't really heard anybody talk about what's the best way to treat that is, of course, by preventing it, right? I think that's really important. And how do you prevent post-dural puncture headache is just by not doing it. And I think, you know, certainly as neurosurgeons, we don't think about that too often. But when you are involved in the CSF leak world, you do think about that a lot. I think from the North American, or at least the US perspective, the number one reason for performing an unnecessary lumbar puncture is a medical legal reason. And I remember when my son was 2 years old and I was a resident in neurosurgery in Minnesota. He had a fever and he was, you know, a little lethargic, and we took him to the ER. And then, oh, they insisted that he needed a lumbar puncture. And I said, you know, I had just immigrated from Holland. And I said, you know what, I'm not going to sue you if he's got meningitis. I really don't think he has meningitis, but they really wanted to do it. They were able to do it after many attempts. But what I still can remember vividly is when they were done with the lumbar puncture, which actually was done by a neurosurgery resident because the pediatrician was not able to get CSF. is that he had literally hundreds of little petechial hemorrhages all over his body. So I thought, yeah, this is really something you only should get if it's really necessary. So we looked not that long ago at a large number of patients, hundreds and hundreds of patients, where we compared CT myelography to heavily T2 weighted MR myelography for patients evaluated for spontaneous intracranial hypotension. And we found that doing the MRI scan was not inferior to performing the CT myelogram. So we actually haven't performed CT myelography for about 10, 15 years, and we really rely on MR myelography, including in patients who have post-dural puncture headaches. And I think I was kind of blown away by this article that was published a couple of years ago in Brain, and they found that actually you should expect somebody to have a CSF leak after a lumbar puncture. And they performed MR myelography in maybe 60, 70 patients who had a lumbar puncture done, and they found that 2/3 of patients get a CSF leak, sort of to be expected. They found a CSF leak in everybody who had a post-dural puncture headache, but they also found it in more than half of patients who did not have a post-dural puncture headache. Now, of course, these MR myelographic studies were performed, if I remember correctly, within 24 or 48 hours after the lumbar puncture. This is just a case that I share a lot with our residents. He was a 27-year-old, and I was on vacation, I believe, and his father was emailing me, oh, my son, he became paraplegic, and he has had trouble since he had a lumbar puncture. So he had had a lumbar puncture when he was visiting his grandparents in Vegas at the age of 10, and it was similar to my son. It also was done to rule out meningitis, but when you talk to the dad, it really didn't sound like meningitis. He didn't even have a fever. He was just, he just had a headache, I believe. So they did the lumbar puncture, and ever since the lumbar puncture, he'd had headaches. And he had been evaluated at some places in the US, and he was told that he had a big spinal cyst in his thoracic spine, but it was not related to his headaches. And then when we saw him, he actually had one of these SLECs, these large ventral collections that you can see here on the MRI scan. The digital subtraction myelogram showed exactly where the lumbar puncture had been done 17 years ago. So this unfortunate man had been suffering with a leak for 2/3 of his life. And then at surgery, you can clearly see there's a little tear that was caused by the lumbar puncture. It was very straightforward to repair, just a little figure-of-8 suture. And postoperatively, the ventral collection was gone. And in the PECU, he started moving his legs again. The paraplegia was completely functional. It was not related to his actual leak, but he had been suffering for so many years that he felt the only way he could get attention was by feigning paraplegia. This is another example, somebody who lives in Orange County. That's the county just south of Los Angeles. And what was interesting is that her post-dural puncture headache did not start until a month after the epidural. And most of the time, when somebody has a persistent leak after an epidural, you don't see it on imaging at all. In this particular case, you could see it, as you can see here on the digital subtraction myelogram. This is where the dural puncture was done, and then it leaks out into the epidural space. And then I'll just talk a few minutes about, something that we see a lot in spine surgery programs. That's the post-op pseudomeningocele. Here you can clearly see where it is. It's very clear at surgery. There's a tiny little hole there that you can see there. It's super easy to repair just with some sutures. And I think whenever you have a post-op patient who's had spine surgery with a headache, it's really a CSF leak until proven otherwise. And I just put these two pictures in just to remind me that, to tell you a story about a patient I saw like maybe 10, 15 years ago, famous movie director here in town. had had spine surgery done at a different hospital, and he'd had headaches ever since, were gone when he would lay down. His internist had referred a patient to me like a year prior, so he knew a little bit about CSF leaks, but the neurosurgeon said, you know what, I didn't see any CSF during surgery. It cannot be a CSF leak. I think it's from high blood pressure. And the patient says, oh, but I don't have high blood pressure. And the neurosurgeon actually went to buy a blood pressure monitor for the patient to see if he had high blood pressure. Well, he didn't. Finally, he came to see me in the office. This was like 6 p.m. The office was really closed. He came to my private office. I did not have a bed in the private office at the time, but he was so sick, he had to lie down on the floor and he vomited on the carpet. So I took him to the operating room the next morning, and he told me that the neurosurgeon actually called him the night before saying, don't have surgery with Schievink, don't do it, because I found out he's not going to put in a lumbar drain after surgery. And a lot of people use lumbar drains, nothing wrong with it, but I just don't think it's really necessary. I just use Diamox, which is a good medical substitute for a lumbar drain. Anyway, the surgery was super simple. It required a single suture, and he was fine. This is another example of how things can go a little bit wrong. This is a 15-year-old boy with Costello syndrome. He'd had a scoliosis surgery done in a different state. Surgery, the mom and dad were told, went perfect. The day after surgery, he started having bad headaches. Nobody picked up on it. 2 years later, he finally sees a neurosurgeon, does a brain MRI, says, oh, you've got a Chiari malformation. Now, mind you, the brain MRI that was done prior to the scoliosis surgery did not show a Chiari. Anyway, he ended up with a Chiari decompression, wasn't any better. And then he went to a different institution where they did a syringo subarachnoid shunt because he also had developed syringomyelia. And during that surgery, they found that he actually had a big leak. They removed one of the screws that they thought he was leaking from, but they couldn't really find it because they went around the dura, and the extradural approach did not show where the leak actually was coming from. And then this is some imaging that we obtained. You can see the syrinx here. He had developed superficial siderosis. This is now after 4 years of leaking. Here you can see where the screw that had since been removed had gone through the dura. You can see some of the hardware, and then this is the dural hole. Now, I'll just also talk a few minutes about what we see much more common, which is post-dural puncture headache with normal imaging. Much more difficult thing to deal with. And when I looked at this recently, really turns out that when you do exploratory surgery, at least when I do it, only about 50% of patients are helped by that. And it's independent of what I find at surgery. So whether I find absolutely nothing or I find an actual dural hole, the results seem to be exactly the same. So I think if you wanted to go ahead with surgery, you kind of have to set the bar high, right? So don't, if a patient says, oh, I have one blood patch, I want to have surgery, I really wouldn't do that if imaging is normal. You have to have a close working relationship with a good headache doctor, because maybe there's a different reason for the headache. Like I said before, we only do MR myelography in that situation. And then at surgery, you can suture it, you can clip it. I oftentimes use a dural graft, Durarepair it's called, which will seal to your own dura after 4 to 6 weeks. And then for a while, because of some people had said, oh, maybe there's an inadvertent ventral breach of the dura, even though you don't see it on imaging. I did exploration of the ventral dura and a little bit of dural reduction, but actually never found any ventral tears. All right, thank you very much.